This conference will now be recorded.
Hello, everyone. Thank you so much for being here today for our presentation on breast cancer, screening, early detection, and breast density. My name is Jennifer Wang, the president of Paradigm Medical. We are a national medical products distributor specializing in post-mastectomy and breast care, lymphedema, and orthopedic footwear and foot care products. Most notably, you will know us as the Canadian distributor of American Breast Care Products. We've been servicing all of Canada for well over 25 years and are headquartered in Toronto. I'm very honored to be introducing our speaker today, Dr. Paula Gordon. She's joining us from Vancouver. Dr. Gordon is the clinical professor in the Department of Radiology at the University of British Columbia and the Emeritus Medical Director of the Sadie Diamond Breast Program at BC Women's Hospital. She is one of Canada's leading experts in breast cancer detection and diagnosis and is a world expert in the field. She was awarded a Queen Elizabeth Diamond Jubilee Medal, is a member of the Order of British Columbia, and has been named one of Canada's 100 most powerful women. Wow. Over the last 30 years, she's been a leading evidence-based advocate for breast cancer screening and early detection, and her work has helped to reduce the number of breast cancer deaths. She's been a tireless teacher, respected researcher, and a great clinician. I am so grateful to have her here today to speak to us. Before I pass it over to Dr. Gordon, I would like to just review a few quick housekeeping items. If everyone can please just turn off their cameras and be sure to mute your device, this will help to minimize any background noise that we all hear. As well, we'll be taking questions at the end of the presentation, at which time there's a chat function on the top right-hand corner of your screen. It looks like a little dialog box. If you type in your questions there, I'll be moderating the Q&A session, so I'll be sure to make sure that everyone's question gets answered. And with that, I will pass it over to Dr. Gordon.
Thank you, Jennifer, and thanks for that lovely introduction. So good afternoon, everybody, and thanks for participating. I'm going to give you a crash course on breast cancer, the options for prevention and screening. I want to introduce you to the important issue of dense breasts, but first let's start with the basics. So here are my disclosures. I'm here on a volunteer basis, and I'm not receiving payment from industry or anyone else to give lectures about breast cancer. Today, I'll explain what breast cancer is and what signs of breast cancer you can look for. I'll stress the benefits of early detection and tell you how to increase the likelihood of catching cancer early if you do get it. I'm going to explain what dense breasts are and why it's critical for you to know if your breasts are dense. And I'll make recommendations for ongoing surveillance for women who've had breast cancer. And as we go through, I'll point out some common myths about breast cancer. So let's start at the beginning. What is breast cancer? It's a disease where a group of cells loses normal control. These abnormal cells grow, usually into a lump, and invade and damage the adjacent normal tissue. They can spread to other parts of the body, like the nearby or distant lymph nodes, but as well, they can go to other organs like the lung, bone, brain, and liver. Now, many cancers can be found before this happens and when they can be more easily treated. Breast cancer is not life-threatening when it's confined to the breast. It's when it spreads to other parts of the body, like the lungs here, like the liver, and to the brain, that it can kill. If breast cancer spreads to the bones, it can cause areas of weakness, and those can fracture easily, even without a fall or other injury. We call them pathological fractures, and like any fracture, they cause pain. This X-ray shows a fracture in the upper left femur or thigh bone, and if cancer spreads to the ribs or spine, sometimes even just coughing can cause a bone to fracture. So, who gets breast cancer? Answer: anyone. You've heard that 1 in 8 statistic, but that's not across all ages. breast cancer is very uncommon, but still occurs in the 20s and 30s. It's when we get to age 40 that there's a jump. And this chart refers to the risk of developing breast cancer in the following 10 years. So at age 40, the likelihood of getting cancer is 1 in 69, and it keeps rising. It never drops. So myth number 1, women sometimes tell me that they don't need a mammogram now that they're 60 or 70, but unless a woman dies of another disease, her risk of breast cancer keeps climbing. And at the other end of the spectrum, I sadly hear from women in their 20s and 30s that they didn't go see their doctor when they found a lump in their breast because they assumed that they were too young to get breast cancer. That's myth number 2. Unfortunately, that is not true. Now, many of you live in provinces where screening mammograms aren't offered to women aged 40 to 49, and some of you may have been diagnosed with breast cancer in a more advanced state as a result of not having access to screening mammograms. In fact, only 3 provinces allow women to start screening at 40, British Columbia, Prince Edward Island, and Nova Scotia. But here on this slide are some important statistics showing why it's important to start at 40. 1 in 6 breast cancers are diagnosed in women in their 40s, and 41% of the years of life lost to breast cancer occur to women who are diagnosed in their 40s. I highly recommend this website, End the Confusion. It has references and lots more information you can read. Now you can copy and paste this link into your browser, or just Google End the Confusion for more depth information. And I'm going to come back to this issue of cancer and screening in the 40s. So we are all at risk of developing breast cancer, but there are factors that can increase a woman's risk of getting breast cancer. Many of them are beyond our control, like these listed on the left, like having one of the breast cancer genes, having had radiation for Hodgkin's disease, having dense breast tissue, having a family history of breast cancer, especially in a first-degree relative like mother or sister, having a previous biopsy that showed atypical cells. Also, if you started having periods early or went through menopause later, or if you've had no children, those can all increase the risk of getting it. Doesn't mean you're going to get it, but can increase the risk. Now, the list on the right is a list of factors you can control to reduce your risk. So minimal or no estrogen use after menopause. Nobody likes hearing this one. Reducing alcohol intake reduces breast cancer risk. A low-fat diet, regular moderate exercise, not smoking, and maintaining a healthy body weight. These are all things that you actually can do to reduce your risk of getting breast cancer. So most of what I'll be talking about today is early detection, finding breast cancer as early as possible, but it would be even better if we could prevent it from even happening. If people modified their habits around those controllable risk factors on the previous slide, and they started in childhood, 68% of breast cancers could be prevented. And even if you wait until middle age to make those healthy changes, as many as half of all breast cancers can be prevented. Here's some other things. Walking 30 minutes a day can lower breast cancer risk by 20%. It also lowers the risk of colon cancer, heart disease, stroke, osteoporosis, and depression. So walking is a really good thing. If you breastfeed for a year total, that's not for one child a year, that's all of your children combined. If you breastfeed for 1 year, that can lower your risk by 20%. Now, I mentioned alcohol in that previous slide. Each drink of alcohol per day, and that includes beer, wine, or spirits, raises breast cancer risk by 10%. Getting to that healthy body weight. If an overweight woman loses 10 pounds, she can reduce her risk by 10%. And if she loses 20 pounds, she can reduce her risk by 50%. So I went through that quickly, but when you get the recording later, you can go through it again. But please remember, we are all at risk. Sorry, this is just that same slide. We are all at risk. Myth number 3, I still hear women tell me, I don't need mammograms because nobody in my family's had breast cancer. Wrong. The fact is 75% of breast cancers occur in women with no family history. So now hopefully if you ever get breast cancer, it'll be found on a mammogram or other screening test before it shows up. But this is a cute graphic from a website called Know Your Lemons, and it shows the different ways that breast cancer can show up. Cancer can be apparent as thickening, which is an area that just feels firmer than the tissue around it. It can be dimpling of the skin. It can be crust on the nipple. It can be warmth or redness of the breast, sores on the skin, or discharge from the nipple. Now, discharge is very common, and when it can be normal, especially if it's white, yellow, or green. But when discharge from the nipple is completely clear like water or bloody, and if it comes out by itself without squeezing, that's when we worry about it. Of course, it can be a bump or lump, but remember, most lumps are not cancer. Rarely, if a vein that you can see through the skin gets bigger, it can be a sign of cancer. Sometimes a breast can change in shape or size. Nipple retraction, that's when the nipple gets pulled in. It can be normal, but if it's something new, it should be checked. And if the skin gets thick and dimpled like the skin of an orange peel, that should be promptly checked. So most lumps are not cancer. Here you see one even just protruding through the skin, but they should be checked. Cancer can attach to the overlying skin and pull it in, so it looks puckered like in this photo on the right. That sign is highly suspicious, so pay attention to your breasts and what they look like when you're undressed. If you see this, you go straight to the doctor. Some cancers show up as a warm, swollen, red breast that can look just like an infection. In these cases, it's reasonable to try a course of antibiotics, but if it doesn't resolve on the medicine, it should be tested for possible cancer. So, why do we screen for breast cancer? We screen to save lives by finding and treating the disease earlier. But also we screen because when we find cancer earlier, it can be treated with less aggressive therapy. When it's found earlier, women can often avoid a mastectomy and have a lumpectomy. They can avoid the armpit surgery called axillary dissection, which can lead to lymphedema, and they can avoid chemotherapy. That's only when it's found early. There are many different tests that can be used to screen for cancer. I'm going to focus primarily on mammography and ultrasound. I don't have time to cover all the others, but I want to make it very clear. Thermography has been thoroughly miscredited. It is not a good screening test for breast cancer. It can find big cancers close to the skin, but those aren't a problem for us. It misses smaller cancers, and it has loads of false positives. And MRI, of course, is reserved for women at very high risk. Now, it's known and accepted that annual screening mammograms starting at age 40 save the most lives. And this is recognized even by organizations that recommend starting later or screening less often than once a year. Now in Canada, I've told you only those 3 provinces, PEI, BC, and Nova Scotia, start screening at age 40. And all provinces should, but I will explain why some don't. Here are a whole bunch of different organizations and their guidelines as to when begin screening, and you can see they vary between 40 and 50. These conflicting guidelines did not arise because of alternative facts. They're because of different value judgments applied to the same facts. So you need to know what those were to see if they align with your values and priorities. This study, Canadian study, compared women who had mammography to those who didn't. They got data on almost 3 million women attending screening programs in Canada. This is the largest study of its type ever published. And they showed that women who attend screening are 40% less likely to die of breast cancer overall. And for women in their 40s who attend screening, it's even better. They get 44% fewer deaths than women who don't have mammograms. A group in Sweden looked at all women aged 40 to 49 diagnosed with breast cancer from 1958 to 2015. They showed that women who had screening were 60% less likely to die of breast cancer in the first 10 years after diagnosis, and they were 47% less likely to die of breast cancer within 20 years after diagnosis. this was a little bit of a different study. They looked at over 7,000 women diagnosed with breast cancer over a 10-year period at 2 of the hospitals in the Harvard system in the 1990s. The majority of deaths, 71% of the deaths, occurred in the women who didn't have regular mammogram screening. Of all breast cancer deaths, only 13% occurred in women over age 70. 31% occurred in women initially diagnosed in their 40s. So with all this data, how can we not be screening all women in the 40s? Well, before we talk about the arguments in favor of screening, let me show you a little bit more about mammograms for those of you who haven't had one yet. This is how a mammogram is done. Each breast is compressed twice, once from side to side like this, and once from top to bottom. A low-dose X-ray is taken in each position. Now, these pictures I got online, and they're supposed to be what to expect when you have a mammogram. Absolutely not. This does not happen. The one on the left shows the technologist and the patient having a lovely time smiling at each other. The one on the right shows the patient standing there with her breast in compression, arms outstretched, while the technologist looks at the image. This never happens. The compression releases as soon as the exposure is made. You are not standing there in compression while the tech looks at the image and decides if it's okay. These are more accurate representations of what having a mammogram is like. Here you see the technologist is concentrating. For the vertical compression image, she has one arm around the patient's shoulders, holding the patient's body as far into the machine as she can. We want the whole breast on that picture, all the way to the back. Her other hand is gently pulling the breast forward while she gradually and gently lowers the compression plate using a switch controlled by her foot on the floor. For the angled picture, she's holding the breast forward, smoothing the skin so there are no wrinkles that can affect the quality of the mammogram. And if she can, she'll even include some of the skin where the bottom of the breast joins her tummy, where this arrow is pointing. And here are what good pictures look like. You can see these are the top to bottom squish pictures. These are the side to side squish pictures. And this lady has a cancer in her right breast, which is easy to see because the cancer is white and the rest of her breast is a dark gray. We'll come back to this. So if we know that mammograms can find cancers early and save lives, and we know that annual screening saves the most lives, let's talk about why all provinces don't start screening at 40 and why we don't screen annually. All women in Canada should have access to screening starting at 40, ideally annually, but we have a mishmash of screening across the country. In 7 provinces, women can self-refer every 2 years, but starting at 50. As I've told you, 3 provinces can start at 40. In my province, women with a mother or sister with breast cancer can come every year. And in some provinces, women are recalled every year if they have dense breast tissue. Now we know annual screening would save the most lives, but none of the provinces offers annual screening to all women. The various provinces that don't offer screening starting at 40 say that there are harms of screening and that they outweigh the benefits. Well, they must be pretty significant harms to outweigh the benefit of saving lives and saving breasts. So let's look at what those harms are and we'll see if you agree. The first one, pain from compression. Yes, absolutely. Mammograms are uncomfortable and they should be, but only for a few seconds, and they should not be excruciating. The reason we compress is to spread out the tissue so we can see better, and that includes seeing cancers. All modern mammogram machines have a release switch that I told you about, so that as soon as the exposure is made, that compression releases. Now, if you've had a previous painful mammogram and it's putting you off going for another one, you should go, but tell the technologist that you had a bad experience and tell her that you will insist that she stops compressing when you tell her to. What I always say is it's better to have a sub-perfect mammogram than no mammogram, and these always turn out fine. Let's spend a couple of minutes now talking about radiation. Now, I know it's a concern for some of you, but not experts, and you'll see why. You may not know that there's radiation all around us all the time. Natural background radiation comes from the cosmos. The sun and stars send cosmic radiation to Earth, and the amount varies with elevation. There's radiation from the ground. Radioactive materials exist naturally in soil and rock. There's radiation in the air. All air contains radon, which is actually the greatest background source of radiation. And even water contains small amounts of dissolved radioactivity. And all organic matter, both plant and animal, contains radioactivity. The radiation risk of breast cancer from a mammogram is primarily in women less than 20 years old. The amount of radiation in a mammogram is roughly equal to the amount you'd receive taking 5 one-way transatlantic flights. Now, the higher you are in altitude, the higher the dose of radiation we get. And this is a result of less shielding of that cosmic radiation by the atmosphere when we're at higher altitude. It may surprise you to know that flight attendants have increased exposure from their work, and they're at a higher risk of getting breast cancer as a result. Another way of looking at it is the dose from a mammogram is similar to the natural radiation you'd receive living for 7 weeks at sea level or living for 3 to 4 weeks in Colorado. To look a little deeper at the theoretical, remember it's a theoretical risk of getting radiation in mammograms, my colleagues at Sunnybrook in Toronto calculated that for 1,000 women aged 50 to 69 having a mammogram every 2 years, it could cause hypothetically 0.27 cancers, not even a whole cancer, and 0.04 deaths. The mammograms would prevent 5 deaths, which is 125 times more than the lives lost, and it would save 105 years of life. So avoiding mammograms for fear of radiation is not a winning bet. And we know that annual mammograms save even more lives starting at 40. So even though there's more radiation with annual mammography, the math is still in favor. This graph is from an excellent website. It's densebreast-info.org, and it shows the radiation you get from various tests. The lowest radiation is from bone densitometry and chest x-rays, and mammography is only a little bit above that. This blue vertical line on the right is the amount of radiation that I'm allowed to get working in an x-ray department every year that's felt to be safe. And that's 12 times the dose in a mammogram. Not that I'm suggesting you have 12 mammograms every year. Going back to the harms of mammograms, the biggest harm in the eyes of the provinces that don't start till 50 is false alarms. That's when a woman has a screening mammogram and gets called back for more tests, but turns out to not have cancer. So it was a false alarm. And here are the numbers on false alarms. For every 1,000 women who have a screening mammogram, 930 or 93% of them will get a normal result. 70 of them or 7% will need additional tests. Now, the majority of them will need only 1 or more additional mammographic pictures. Some will need ultrasound, and 16% or 11 of the 70 that we recall will be advised to have a needle biopsy. Now, those are done with local freezing, and they should not be more significantly painful than just having a blood test from the arm. And of those 11 women who have a needle biopsy, 4 of them will be diagnosed with breast cancer. So even when we tell a woman she needs a needle biopsy, the results are still more than 50% that she will not have breast cancer. Provincial screening programs think that we should spare women the anxiety of a false alarm, and that's why they recommend starting screening later and screening less often, even though they know more women will die. Do women think that false alarms are a reason to not recommend screening? Researchers in Pittsburgh studied this. They surveyed all women attending for routine screening over a 5-month period in 2004-2005. And 97% of the women said they would have regular screening even if it meant having a false alarm. 86% said they'd be willing to be recalled more often for more tests. And 82% said, no big deal, I'm happy to have a needle biopsy if it might increase the chance of detecting a cancer early. So that's what you have to consider when you decide whether to have a mammogram. Remember, 4 of the 11 needle biopsies that we recommend show cancer. Dr. Lee in New York studied the effect of education for the public on anxiety and found that women felt empowered and more confident in the decision process and more willing to attend screening after hearing a lecture. So that's why I'm doing this today. After this lecture, hopefully you'll feel the same and you'll feel more comfortable going for a mammogram. Now, overdiagnosis is the possibility that some cancers we find at screening would never surface in a woman's life, so there's really no need to know about them. And it's probable that of the cancers we find, some of them may grow so slowly that they might never become life-threatening. We don't know yet how to recognize them at the time of diagnosis, though. It's also possible that a woman might die of something else before her cancer becomes life-threatening, like heart disease. Let's say she has a heart attack, or let's say she gets a different cancer that grows faster and kills her, or let's say she's in a car accident. The challenge is most of us don't have a crystal ball. If you knew that you were going to be in a car accident tomorrow or die of a stroke 6 months from now, then you don't need a mammogram. But I don't have a crystal ball either. So to paraphrase Dr. Helvey from Michigan, many women are willing to accept some short-lived anxiety from a recall if they are recalled for more tests in order to reduce the likelihood of dying of breast cancer. And if you agree with that philosophy, make sure you tell your doctor. So where did the provincial screening programs get the idea that the significant benefits of early detection weren't worth finding cancers as early as possible? Well, there's a committee in Canada called the Canadian Task Force on Preventive Healthcare, and they make guidelines on screening for cancers, including breast cancer. Now, you'd think that they would have experts on breast cancer on that committee that makes these breast cancer guidelines, like maybe a breast radiologist like me, maybe a surgeon or an oncologist, maybe all three, but they don't. It will shock you to know they deliberately exclude experts. And on that committee, there are family doctors and some other health professionals. The breast guidelines also had a kidney specialist, an occupational therapist, and even a chiropractor. The Canadian Task Force acknowledges that annual screening starting at 40 saves the most lives, but they think the harm of transient anxiety outweighs the benefits of early detection. So here's what they recommend. No routine screening until age 50, and then only every 2 to 3 years. They say that doctors should stop doing breast exams, and they said that women shouldn't do breast self-exams, and they recommend no supplemental screening for women with dense breasts. This comic from the newspaper in Vernon sums up their recommendation. Don't worry your pretty little heads about it. Now, the reason they came to those recommendations is that they exaggerated the harms and they underestimated the benefits of early detection, and they concluded that the harms outweigh the benefits. But I hope you agree with me that the harm of transient anxiety is not equal to the increased deaths when women aren't allowed to have screening mammograms. When the US task force made similar recommendations a few years ago, Drs. Helvey and Hendrick looked at the consequences for those recommendations for women turning 40 in the next 10 years. And they calculated that 100,000 more women in the US would die of breast cancer every year by starting at 50 and screening every 2 years compared to annual screening starting at 40. They think that we should have overdying instead of some transient anxiety. These are the value judgments I spoke of earlier that explain the differences in screening recommendations among different organizations. Now, some people who don't think we should have optimal screening argue that because we have such good chemo nowadays, we don't have to find the cancers as early. That's myth number 4. That's not true. This study from the Netherlands of almost 174,000 women showed that even with modern therapy, survival still depends on early diagnosis, which relies on optimal screening. And besides, who would choose chemo if they could have early detection and avoid chemo? So it makes sense to screen women in their 40s, even though women 40 to 49 are not offered breast cancer screening in most provinces. These younger women have the most potential years of life to lose if they have a cancer that's undiscovered until it's advanced. They're often caring for young children and aging parents. They're working and contributing to the economy, and they're not expendable. So when should screening stop? This life expectancy chart is from Statistics Canada. The average life expectancy for a 75-year-old woman is 13 years. At age 80, it's 10 years. The American Cancer Society recommends that women keep having mammograms as long as their life expectancy is 10 years. So stopping at 80 might be reasonable, but it depends on your general health and your personal values. I have a friend who's 84 and active. She just bought a bike last year and she rides 10K 3 times a week, and she's still having mammograms. The Canadian Task Force recommends stopping screening at 74, and most provinces have defaulted to that. But if a woman's in good health like my friend, with a life expectancy of 10 years and is well enough to have treatment if a cancer is found, then it's worth continuing screening to find those cancers when they're small. Most can be removed with just local freezing, and older women usually don't need chemotherapy or radiation. But if allowed to grow large enough to be found as a lump, more extensive surgery might be required. And for some women, by the time a lump is found, their health may not be as good, and she may be less able to have treatment. So myth number 5, there's no set age when a woman is too old to have a mammogram. Now, these 2 studies are from clinics that screen all referred women. They're from the US. And they showed that in their patient population, up to 10% of their patients having screening are 75 or older. In that age group, they are finding a high number of cancers. They're finding between 6 and 8 per 1,000 women. Most were invasive, and 98% of those women went on to have surgery. So now many organizations recommend, and I agree, that an individual woman's decision to continue screening should be based on her health, her life expectancy, and her values. Speak to your doctor if you want to continue screening. In some provinces, women can continue to self-refer to have a mammogram up until age 74, but after that, they might need a requisition from their doctor. Now, here's something important for you to know. The task force, when they were looking at data about screening, they only looked at the kind of studies called randomized controlled trials to determine the benefits of screening. And they ignored more recent studies using modern mammogram machines. But randomized trials can only show one thing, and that's the mortality and whether there's mortality reduction. So that's how they estimated and underestimated the benefits of early detection. The other benefits I mentioned before that our task forces didn't consider were the option to have a lumpectomy instead of mastectomy, the option to avoid armpit surgery and have a sentinel node biopsy, and the option to avoid chemotherapy. So finding cancer early can mean the difference between having a mastectomy and having a lumpectomy. When Dr. Nick Perry left his position, he was the director of the London Breast Screening Program in the UK. He opened his own clinic called the London Breast Clinic and offers screening for women who want to attend earlier or more often than is offered through the National Health Service in England. They only screen every 3 years from age 50 to 70. And soon after, he presented his data on 184 women diagnosed with breast cancer in their 40s. And he looked at the rates of mastectomy in relation to how recently the last mammogram was done. For women who had a mammogram in the preceding year, 22% needed a mastectomy. But for women who had mammograms less often, over half of them needed mastectomies. These researchers from New York showed the benefits of early detection. Women who had screening mammography less often than every year are more likely to need chemotherapy. They're more likely to have mastectomies and require axillary dissection. And remember, that's what most women in Canada get every 2 years from age 50. Now, some of you may know what this is. For those of you who don't, this is what lymphedema can look like. This is a pretty significant case, though. It can be quite mild and almost inapparent. But lymphedema is swelling in the hand and arm from blockage of the lymphatic vessels in the armpit, which is a side effect of that armpit surgery that used to be done routinely as part of breast cancer lymph node staging. It's permanent, and as you can imagine, it's life-changing. It's arguably the worst part of breast cancer for many women. When cancer is detected early, women can have a different kind of biopsy called a sentinel node biopsy instead of an axillary dissection with a much lower risk of lymphedema. Chemotherapy is awful, but unlike lymphedema, it's not forever. But now, with genomic testing of the actual tumor, many women can avoid chemo if their cancer is small and if there are no positive nodes, and if they're determined to be at low risk of the cancer coming back. This is another reason to find cancers early that the task force didn't even consider as a benefit of screening. So why is breast density important? Well, we are pretty good at recognizing a breast cancer on a mammogram when it's visible. And here's an obvious cancer in a 55-year-old woman. And the reason I can say it's cancer is because it's got these jaggedy edges and these fine white dots you can see better in this magnification picture that are suspicious calcifications. And the reason it's easy to see this one is because cancer's white and the rest of her breast is dark gray. Now just remember this cancer for the next few slides. It's relatively easy to see cancer when the breast is mainly fatty, like in this one, and fat is dark gray on a mammogram. I often say to women, this is the one spot in your body where you want to be fat. If she had a cancer from a few slides ago, we'd have no trouble seeing it. These breasts are also normal, but they're not all gray. There's a little bit more white tissue than on the last slide. And it's normal breast tissue. And white is the opposite of fat, and we call it dense because it blocks the passage of X-rays through the breast. Now, we have a good chance of seeing that cancer from a couple of slides ago in this breast. These breasts are normal too, but look, they have way more dense tissue. It becomes harder to see cancers that are white while the breast tissue around them is dense. And it would be challenging or impossible to see that cancer in these breasts, but it's hiding here. You just can't see it. And in some women who have virtually no fat, they're completely dense, extremely dense. Even a large cancer could be missed in this woman. It would probably be impossible to see that cancer in these breasts. Now, mammograms find 98% of cancers in women with fatty breasts, but they find less than 50% in women with the densest breasts. Now let that sink in. We miss over 50% of cancers in women with the densest breasts. So for women with dense breasts, it's potentially harmful for them to not know their breast density, because if they're told that their mammogram is negative, it can give them a false sense of security. And you probably all know of women who ignored a lump because they'd recently had a negative mammogram. So a negative mammogram is not always positive news. And even important people can get confused with what negative and positive mean.
And I tested very positively in another sense. So this morning, yeah, I tested positively toward negative, right? So no, I tested perfectly this morning, meaning I tested negative.
Hope you had a giggle with that. This animation shows why we say that looking for cancer in a dense breast is like looking for a snowball in a snowstorm. You can see how easy it was to see a cancer in the fatty breast, and we completely can't see it in that dense breast. Radiologists, did I miss a slide? Yes, radiologists divide breast cancer into 4 density categories like I just showed you, A to D. And this is called the BIRADS density system. It was created in the 1980s. Categories C and D are called dense, and categories A and B are non-dense. Now, breast density can decline as you get older, but it doesn't always. You can have a young woman with fatty breasts and an elderly woman with dense breasts. Here's a real-life example of dense tissue hiding a cancer. This woman had a negative mammogram at age 50, and you can see that her breasts are largely dense. 8 months later, she came back after finding a lump in her left breast. You can see the triangular sticker that the technologist taped to her skin over the lump. And we repeated the mammogram, and it's still negative even when we use 3D mammography. But when we did her ultrasound, we saw a 3.2 centimeter cancer, and it had already spread to her lymph nodes. Now, when a cancer is diagnosed after the most recent screening mammogram is negative, it's called an interval cancer. And interval cancers are 18 times more common in women with dense breasts. And we see cases like this every single week. Here's the thing. Dense breasts are normal and common. Every woman has fat, glands, and breast tissue in her breasts, but the proportions vary from one woman to the next, like the A to D that I just showed you. More than 40% of women aged 40 to 74 have dense breasts. And as I said before, Breasts may become less dense as women get older, but not always. Now, women with at least 50% density on their mammogram make up a significant proportion of the screening population. Over half of women in their 40s have dense breasts, and almost a third of women in their 60s have dense breasts. And while it's normal to have dense breasts, women need to know if they have dense breasts because they need to understand the implications. In Canada, there are 3.4 million women over age 40 with dense breasts, and over 800,000 women in Canada are in that highest density category D. So here's why it's important to know if you have dense breasts. Women in category D have 4 to 6 times higher risk of developing breast cancer than women with fatty breasts. And as you've seen, dense breast tissue and cancer both appear white on a mammogram. So not only are they at a higher risk of getting breast cancer, their cancers can hide in dense tissue. So cancers in women with dense breasts on average are larger and more often node positive than in women with fatty breasts. That's why women with dense breasts have 18 times higher risk of an interval cancer, like the lady I just showed you. And these cancers have a worse prognosis than cancers that we find at screening. So how do you know if you have dense breasts? You can't tell by touch. Breast density can only be determined by the radiologist when looking at your mammogram. Your family doctor can't tell by doing a physical exam, and neither can you by doing breast self-exam. Lumpy breasts are not the same as dense breasts. Both fatty and dense breasts can feel soft, firm, or lumpy. And some provinces are starting to use software to measure the level of density, but most provinces it's just us looking at the image. So where does ultrasound fit in? Well, for many years it was believed that ultrasound couldn't find cancers if they weren't visible on the mammogram and they were still too small to feel. We published this paper over 25 years ago, and it was followed by work from multiple other researchers. It showed that high-resolution ultrasound can find cancers that are too small to be feelable and missed on mammograms largely because of dense tissue. This trial found 5.3 cancers per 1,000 women screened with ultrasound in the first year of their study, and an average of 4.3 cancers over all 3 years. 94% of the cancers they found were small, invasive, and not yet spread to the lymph nodes. This is when we want to find cancers, when they can be treated less aggressively. Ultrasound can be done either with a handheld probe or with a large probe that automatically scans about a third of the breast, sometimes called ABIS, for automated breast ultrasound. And I understand that ABIS is available at some clinics in Ontario and Alberta. Now, any ordinary ultrasound machine can do breast ultrasound, but not all clinics offer it, and it may not be covered by provincial health insurance. So in spite of all the emerging evidence on breast density, it was still not being shared with women, and in many cases with their doctor. Nancy Capello was a PhD in educational leadership in Connecticut. In 2004, only weeks after her routine annual screening mammogram was negative, she found a lump in her breast, and after ultrasound showed a cancer, she was diagnosed as stage 3C with 13 positive lymph nodes. She started a grassroots movement in the US to get women notified when they have dense breasts. And since the medical establishment pushed her away, she went to legislators, and there are now 38 states with some degree of breast density notification legislation. The FDA in the states has mandated that starting next year, all women in the US will be informed of the risks of dense breast tissue and told their breast density on their mammogram reports. Because she was in Connecticut, Connecticut was the first state to legislate, and they now have several years of data. They're finding an additional 3 to 4 cancers per 1,000 women screened year after year. And these are cancers that were missed on their mammograms. Now, thanks to the efforts of Dense Breast Canada, that's a nonprofit education and advocacy group, BC was the first province in 2018 to inform all women of their breast density when they have a screening mammogram. And since then, PEI, Nova Scotia, and New Brunswick do as well. Currently, Manitoba, Saskatchewan, and Ontario only tell women in category D that they're dense. So, and there's also advocates active in Europe. Both France and Austria offer screening ultrasound to all women with category C and D density. Now, I hope you're learning a lot from what I'm telling you, and it may surprise you that your doctor may be completely unaware of all this. They may be unaware that having dense breasts gives you a higher risk of getting breast cancer. They may be unaware that having dense breasts is a stronger risk factor than having a family history. They may not know that women with dense breasts are 5 times higher risk than those with fatty breasts. And they might not know of the greater likelihood of a cancer being missed on a mammogram when breasts are dense. That 50% of cancers are missed in women with the highest density, and they may not know that ultrasound can find cancers that are missed on the mammogram when the breasts are dense. So what if you have had cancer? Well, it's been known for some time that women who've had cancer are at a higher risk of getting a second cancer in the same breast or the opposite breast. And this study showed that you've had cancer in one breast and you have dense tissue, you're at a higher risk of getting cancer in the other breast than a woman who doesn't have dense breasts. These researchers also showed that getting cancer in the other breast is higher in women with dense breasts. They also showed, let me go back, sorry, that breast density can decrease in women on tamoxifen or on chemotherapy, but not radiation. And if breast density decreases more than 10%, that women may be actually getting to be at a lower risk of getting breast cancer on the other side. Now, after lumpectomy and radiation, the overall risk of cancer coming back in that breast, that's called local recurrence, is about 10 to 15% over the next 10 years. But patients with high mammographic density have a much greater risk of the cancer coming back in that breast compared with women who have the least dense breasts. So the risk is 21% in women in category D compared with 5% in category A. And the risk of local recurrence at 10 years was higher for women who didn't have radiation than for those who did. That's actually why we give radiation after lumpectomy. So what about screening for women who've had a mastectomy? Well, it depends on what kind of mastectomy, whether you've had reconstruction, if so, what kind of reconstruction. Women who've had nipple-sparing mastectomy still have breast tissue in and behind the nipple, and they usually have enough tissue to compress for a mammogram. So they should have one, and if they're dense, they should also have ultrasound or MRI. Women who've had a complete mastectomy and no reconstruction typically don't have enough tissue to see in a mammogram, so mammography wouldn't be useful. They should have checkups with the doctor and they should do breast self-exam. Any change, even a pimple in the skin, should be checked. The same thing for women who have implant reconstruction. There's not enough of their native breast tissue to pull forward off the implant to look at on a mammogram, so just checkups with the doctor and breast self-exams. If they've had a mastectomy with a flap reconstruction, that means using their own tissue to do the reconstruction, it's worth doing a mammogram because if the cancer comes back, we can usually see it before it's large enough to feel. But if they've had a prophylactic mastectomy, in other words, they had breast cancer on one side, no cancer in the other breast, but they elected to have the other breast removed, the side of the prophylactic mastectomy doesn't contain any breast tissue, and so it doesn't need a mammogram. So here's what you should do if you have dense breasts, whether or not you've had cancer in the past. Continue having regular mammograms because they can detect cancer not visible on the ultrasound. Do breast self-examination, ideally every month after your period if you're still menstruating. And if you notice any change, see your doctor, even if you just had a negative mammogram. Excuse me. Consider modifying your lifestyle factors to decrease cancer risk, such as getting to and staying at a healthy body weight, doing regular moderate exercise, decreasing your alcohol intake and decreasing hormone use. And most important, advocate for yourself. Ask for a screening ultrasound if you have dense breasts. And if you've had breast cancer and your diagnosis was delayed because of dense breast tissue, please consider sharing your experience with Dense Breast Canada. The best way to inform and empower other women is through stories, and you can reach them on their website. I'll give you that later. So how do you do breast self-examination? Not like this. If you Google how to do breast examination, you'll see a bunch of pictures of women doing this with their clothes on. Breast self-exam pamphlets used to be widely available, but the term breast self-exam has fallen out of favor, largely because of our friends at the Canadian Task Force. The term you'll hear now is that women should be breast aware. In plain English, it means pay attention to how your breasts look and feel. You don't have to do diligent breast self-exam every month, but I'd argue if you don't know what your normal breast texture feels like, you won't recognize if there's been a change. So be familiar with the shape of your breasts with your hands in different positions. Here with the hands by the sides, hands outstretched, hands up in the air. That puckering I showed you before, this would be more conspicuous and easier to see if a woman was looking in the mirror with her arms raised. You can check your breasts lying in bed or in the shower. Soapy hands make it easier to slide your hand along the skin and make it easier to notice normal texture or a lump. Women often say to me, I don't like doing breast exams. I'm just going to let my doctor check my breasts. Myth number 6, first of all, if your doctor may not even do a breast exam if they follow the Canadian Task Force guidelines. Secondly, you can be more of an expert in what your normals feels like than any health professional. Even if your doctor still does do breast exams, they might examine several women a day. And just like mammograms vary from one woman to the next, breast texture varies considerably between women. Even if a doctor makes a diagram in your chart, they won't remember a year later what your breast felt like. But unless you're a doctor or a nurse, you are the only one you are examining on a regular basis with breast self-exam, so you'd be more likely to notice a change. Speak to your doctor about your level of density, the associated risks, any additional risk factors you have, and the best screening options for you. To improve early cancer detection in dense breast, consider additional screening such as ultrasound, or if you are at high risk, MRI. The American College of Radiology now recommends that women who've had cancer and who have dense breasts should have mammography and MRI every year. And they recommend MRI for women whose cancer was diagnosed before the age of 50, even if they don't have dense breasts. Those recommendations are not routine in Canada, but please advocate for yourself with your doctor. And if they won't do MRI, at least look as well an ultrasound. So here's what I want you to remember from all that information. All women should have mammograms, ideally starting at age 40 and ideally annually, but certainly go as often as your screening program will allow. Some cancers are not detectable on mammograms, so it is worth doing breast self-exams. Get to know what normal feels like so you'll know if there's been a change. Remember, most abnormalities on mammograms are not cancer, so don't panic if you get recalled from a screening mammogram, and don't panic if you find a new lump in your breast, just don't ignore it. Women who have mammograms are 40% less likely to die of breast cancer than women who don't. And when you look at the real numbers for mortality reduction and the other benefits of early detection, the benefits certainly outweigh the harms of having mammograms. Ultrasound can find cancer that's missed on mammograms in dense breasts. Even if 3D mammography was used, we still find more cancer using ultrasound. And remember the two risks associated with having dense breasts. The risk of getting breast cancer is higher, and the reduction in the accuracy of the mammogram in women with dense breasts. It's important to know your density and understand those implications, and please speak to your doctor about your risk factors. There's also an excellent online calculator of risk that you can find on the Dense Breast Canada website. So for more information on breast density, look for the Dense Breast Canada website. They're also on Facebook, Twitter, and Instagram. And the website I told you about, densebreast-info.org. Here's how you can reach Paradigm Medical. They are recording this and you will get a copy. And if you don't, get a hold of them and ask for one. And thank you again so much for your attention. Happy to take questions. You can take over, Jennifer.
Great. So we do have some questions already lined up. Okay, so from Cherie, her question is, does the success or stats of a lumpectomy take into account those women who have their lumpectomy followed by a mastectomy on the same breast?
So the women who have a mastectomy after a lumpectomy are usually women who either right after the lumpectomy, they realized that they didn't have clear margins, and the cancer was more extensive than they realized, so the doctor goes ahead and does a mastectomy. Or sometimes a woman can have a lumpectomy, and another, if she gets a local recurrence even years later, the proper thing to do, or the most advisable thing, might be to do a mastectomy. So yes, the stats include the women who had lumpectomies and mastectomies.
Okay. Cherie has another question too as well. Is there a reason that surgeons leave a dog ear behind after breast surgery?
I don't think it's intentional. I mean, don't forget you're lying down when they do the surgery, and they make it look neat and tidy, but then later when you're upright, there may be that little bit of extra tissue hanging there. Also, it might be gorgeous to begin with, but if you gain weight and you're unlucky enough to put weight on in that spot, and so you know that some women, I'm sure the fitters know this, some women have a little extra pouch of fat in the, what we call the axillary tail, close to the armpit. So if you gain weight, even after your perfect surgical result, you may be unlucky enough and put it on there.
Mm-hmm. So we've got another question. Is it still correct to not have blood taken or blood pressure taken on the surgical side following a mammogram? Wearing a watch or wearing a watch on the surgical side?
That's a really good question, and it's really outside my area of expertise. And I get asked that question because if women are going to have an MRI and they need to have the intravenous injection for the MRI, ideally they're told to not inject it on the side of the breast cancer surgery. But that's a good question to take up with the surgeon or oncologist.
Mm-hmm. So Dr. Gordon, what is your feeling on underwire in a mastectomy bra?
I don't have an opinion. I know that there's an old wives' tale out there that underwires increase the risk of getting breast cancer, and that's not true. There's also a myth that deodorant causes breast cancer. It doesn't. So I would say you're going for a combination of comfort and a nice cosmetic result.
So personal choice.
Yes.
With self-referral for a mammogram, who can tell if you have dense breasts? The mammographer?
The radiologist reading the mammogram, and not all places are up to speed yet, but when a radiologist reads a mammogram, they don't just read it and say positive or negative. They should actually state the breast density in their report. Sometimes it's just checking off a box, and sometimes it's in a paragraph, but that information should be in the report. And not all provinces are telling women their density yet, but that is one thing that the Dense Breast Canada is working towards, advocating that all the screening mammograms in Canada should be telling women. If you have a copy of your last screening mammogram report and the density is not measured, I would recommend you contact the head office of your screening program and ask what your breast density is. And if your province is not telling women, then get on the bandwagon and fight for it.
Okay, so another question. Why do some surgeons refuse to do a DBL mastectomy when there is cancer in one breast and other surgeons will do it?
DBL, you mean a double mastectomy? I can't answer. I think some surgeons believe that a woman will regret it later. So having a cancer diagnosis can be terrifying, of course, and women ask for what they think will give them the greatest peace of mind. A woman can say, my cancer wasn't found until it was big because I have dense breasts. I don't trust keeping my other breast because you're not going to let me have ultrasound or MRI, and I don't trust mammograms anymore. I want the other side removed. I think that's a completely legitimate request. But if the surgeon thinks, oh no, she's going to miss that breast, she's going to want it later. If I take it off, she's going to regret it. That's kind of patronizing to not give the woman what she's asked for. I would say go see another surgeon.
Mm-hmm.
What you want.
So a question from Laurel, which I believe we may have already answered, is dense breast density, likely to be recorded on one's medical chart?
In some provinces, yes, in others not. And like I said, if you can get a hold of your last mammogram report, and if they don't say what the density is, and they may not use the ABCD category, there are some provinces I mentioned, they don't use ABCD, and if they just are one of the provinces that only tell women in the highest category that they're dense, the Ds, that is really misleading, because a woman who's category C, who has dense breasts, who is at risk, she might be misled into thinking that she doesn't have dense breasts. So you want to know what category, A, B, C, D, and if your province only does it, say, by saying greater than 75%, that's the old-fashioned way of saying D, that's not good enough. You want to know, are you a C? Are you in the 50 to 75% category?
A question from Sharon. The breast is divided up into quadrants. Is there higher risk of cancer in different quadrants?
Yes, it's highest in the upper outer quadrant. That's the breast tissue closest to the armpit, but breast cancer can occur anywhere.
That's good to know. From Dana, women who have breast implants still get mammograms. I have heard that there usually is not enough tissue to do one, that ultrasound is better.
So women who've had first of all, women who has an implant for augmentation, for cosmetic, to make her breast look bigger, they still have all their own breast tissue, and we can do mammograms in them. The technologist can feel where the implant starts, and what she does is she pulls the woman's breast tissue forward and pushes the implant back out of the way, and we take a picture like that, and then we take a picture with the implant in. But women who've had a mastectomy and an implant reconstruction, we typically do not do mammograms on them, because there is all you've got is skin there. That's not enough to get a good mammogram. And because there's no breast tissue, you're in the same situation as a woman who's had a mastectomy with no reconstruction. If there's any breast tissue at all, it's just under the skin, and you'd be able to feel a cancer when it's small better than we'd be able to see it. So we don't do ultrasound in women who've had a mastectomy and an implant.
Makes a lot of sense. Sharon, a question from Sharon. Is inflammatory breast cancer more common in women who have dense breasts? And then she also has a second question. Is lobular breast cancer more common in women who have dense breasts?
Both good questions. First of all, inflammatory breast cancer, it's not a cell type. It's not a type of cancer. What inflammatory refers to is what the breast looks like when you look at it. That's the one I showed you with where the breast is warm and hot and looks like an infection. And the reason is because the lymphatics that come from the skin are blocked, and so the skin is getting hot and warm. That can happen in any breast density. So having dense breast doesn't make you at a higher risk for getting an inflammatory breast cancer. Invasive lobular carcinoma accounts for about 10% of breast cancers, unlike the more common invasive ductal carcinoma, which is almost 90%. And it's not necessarily more common in dense tissue. It's hard to see, not because it hides in dense tissue, but because it doesn't form a lump. It grows along tissue planes almost in a single file pattern. And so that can make it hard to see. Even in a woman with fatty breast tissue, we can miss an infiltrating lobular. So those are the ones that often show up as a thickening that you can feel, where the tissue just feels thicker than the stuff around it.
Great. Are there any other questions? That was the last one I have in the chat room.
So everybody follow me on Twitter. I'm a big mouth when it comes to advocating for optimal screening.
And yes, and everyone, please spread the awareness from what you've learned today. If you have any other questions, don't hesitate to contact us at Paradigm Medical. We will be recording it and we'll post it on our YouTube channel. So if you do have any friends or people who might be interested in learning about this topic, please do share the link. We will follow up with everyone with the link for the recording. And if you have any other questions, don't hesitate to reach out to us. We have a couple last questions. One from Kathy: is the ABU US the optimal screening?
No, it's so ABIS is just another technology. The handheld ultrasound is just as accurate. Anything we do in imaging depends on the skill of the person taking the pictures and the skill of the person interpreting the pictures. And so, so there's not a lot of places doing either test in Canada. We hope that's going to change, but no, ABIS is sometimes all that's available because it doesn't require a highly skilled technologist, and there's a shortage of ultrasound techs. So if you can get a breast ultrasound screening and all they've got is ABIS, go for it. If you can get it with handheld, go for it. The other thing I'd just like to say before we end is the only reason we've achieved as much as we have with women being told their density and ultrasound being more recognized is through the hard work of the women at Dense Breast Canada. These are women who've had cancer. Many of them, their cancer was delayed in diagnosis because of dense breasts, and they're trying to make things better for other women. If you have the energy to help out with advocacy, please contact Dense Breast Canada. You can go on their website. They also have brochures about dense breasts if anybody's interested.
Wonderful. Also, just a special thank you to Jeannie for helping. Jeannie's one of the co-founders of Dense Breast Canada. Thank you for helping to coordinate and organize this presentation today. And I think if there's no other questions, we could wrap it up.
Thanks for hosting.
Thank you for everyone for attending today. I hope we found it very useful, the information. Take care.
Great. Bye now. Yep, take care. Be safe.